Welcome to the Health Workforce Technical Assistance Center's Webinar Series. This webinar is entitled State Health Workforce Data Collection, Opportunities and Challenges, presented by Katie Gaul on February 12, 2014.
Thank you very much. Welcome to the first Health Workforce Technical Assistance Center's webinar. We are talking today about state health workforce data collection, opportunities, and challenges. I am Katie Gaul, and this is based on work that Aaron Freyer and I have done for the last 10 years through the Program on Health Workforce Research and Policy at the Shupp Center for Health Services Research at UNC Chapel Hill. So, where we've been informs who we are and where we're going. I'm going to talk to you a lot about what we do here in North Carolina, and that starts with the North Carolina Health Professions Data System. The HPDS, the Health Professions Data System, HPDS as we call it, is housed within the Program on Health Workforce Research and Policy here at the Shupp Center, as I mentioned. We were created way back in the 1970s with a federal health manpower grant, as it was called then. And since then, our North Carolina AHEC program has provided our core funding to maintain the data system. So our mission is to provide timely, objective data and analysis to inform health workforce policy in North Carolina and the United States. We have three main service lines. One is to provide data and research to those who need it for research projects, for policy, for whatever they need it for. We conduct policy analyses, and then we do engaged scholarship that serves the state and the nation. So we do research on the health workforce, looking at supply and distribution and things like that, and provide that research to those who need it.
We're a collaboration between the Shupp Center, the North Carolina AHEC program, and our Health Professions Licensing Boards in North Carolina. The data are provided voluntarily to us by the board. There's no legislation that mandates this, and there's no appropriation either, no direct appropriation. We have over 30 years of continuous, complete licensure data on 19 health professions licensed by 12 different licensing boards. It's important to note for our purposes that these are not survey data, these are licensure data, so we have very good response rates. The data come from initial applications for licensure and subsequent renewals. The licensure data are housed at the Shupp Center, but they remain the property of the licensing board at all times. Each time that someone requests an analysis file or a mailing list or any identifiable data, we need to seek permission from the board before we can give out those data. We are independent of government and healthcare professionals. We are not housed within our State Department of Health, for example, and we are not housed underneath, say, the North Carolina Academy of Family Physicians. We are independent in our own right. And this brings rigor and objectivity to the work that we do. People trust our data. We don't have an agenda for any one profession. Our core funding is provided by the North Carolina AHEC Program Office. We also generate some revenue through data requests. Our staff are cross-subsidized on other grant-funded projects at the Shupp Center, and we also receive a little bit of money from the UNC Chapel Hill Office of the Provost. So why are we here? Well, because we want to learn more about developing health workforce data systems. Why do we want to set up data systems? So we can do better workforce planning. And why do we want to do state-based workforce planning? I'll get more to the why in a few minutes. But states have their own role in implementing the Affordable Care Act. Those activities have implications on workforce. So, for example, states choose whether or not they want to expand Medicaid. What's that mean for the workforce in those states? The state picture varies from the national picture. There's local and regional variations that national data don't always capture. If you collect state data, you know your data better, and you can identify those nuances. Many of the policy levers that we have are at the state level. So, for example, scope of practice, legal scope of practice is set at the state level. Decisions about whether to enact or change policies that are directed at training, recruiting, and retaining health professionals, they affect a wide variety of stakeholders and they're also the source of contentious debate. Lots of fights and turf wars happen. If you have data to help inform those discussions, it helps to have that evidence base. So what kinds of questions might your state be asking? So, for example, in North Carolina, our General Assembly has been asking if we're going to have enough of, pick a profession, are we going to have enough nurses? Are they going to be in the right specialties? Are they going to be practicing in the right places? And are they going to be in the right geography to meet future demand? We've also been asked, do we need a new school of pharmacy? Do we need a new school of optometry? So we're running some data for the General Assembly and the UNC Board of Governors this week. We've also been asked, what's the distribution of certified nurse midwives, OB-GYNs, and family docs who say they're delivering babies? What's the age distribution of the current workforce? We're looking at our pharmacy workforce right now, and we're seeing a very good age distribution. There's no big bulk of people that are going to be retiring in the next 5 to 10 years. It's pretty solid. And then what's the current breakdown of ADN versus BSN nurses? How do we know if we're getting closer or making progress toward the 80% BSN by 2020? So how do we know the answers to those questions, you might ask? Well, we need data. And there are different strokes for different folks. I love this slide. There are different ways that states collect data. Some states don't collect data. Some of them don't analyze data beyond what's already needed for regulation of licensure. State licensure boards vary from state to state. Some are independent entities, like they are in North Carolina. Some are housed under state government. And some are housed under one umbrella under state government. And the capacity of states to collect and analyze data differs. Some states have great capacity. Some have really solid funding because they've made this a priority. Some have really good partnerships, but others don't. And a lot have good stakeholder support, but then again, others don't. As I've talked to different states over the years, I have observed 4 general methods of data collection. And if you know of any others, if your state is doing something different or wants to do something different, I would love to hear it. So, for example, in North Carolina, we use the licensure process to collect our data. We get 100% of the workforce because everyone has to be licensed. Other states use surveys. So New York has historically done surveys to track registered nurses in their state. Other states do this as well. Some states engage in what I call continuous monitoring, and the best example I know of is Iowa. They started with a complete roster of their physicians way back in the 70s like we did. But then instead of keeping up with licensure data, they would keep track of individual physicians. They would survey practices and licensees. They would track newspapers for new hires, retirements, deaths, changes in practice. And so they've been able to keep track of their folks all along, and now they're expanding to other professions as well. And then this 4th one is really intriguing to me, and I don't know much about it yet, but I know that some states are looking at trying to use their all-payer databases. So what they do is they use their claims data to try to enumerate the workforce and describe their practice characteristics. And so if your state is looking at doing this, I'd also like to talk to you a little more because I want to understand better how this works. So to mandate or not to mandate, in North Carolina, there is no requirement that our boards share their workforce data. There's no requirement for us to do our work in tracking the health workforce in our state. But some states do require, by statute, the collection of health workforce data. And this leads to different levels of flexibility in how they collect the data. So, for example, in Florida, they are every time they want to change a question on their licensure form, it has to go through public review. Some states do not require data collection. I already talked about us. But in those states, you need good relationships to keep things going. Good relationships foster trust. If you trust each other and you're rowing in the same direction, things can get done. Challenges to legislation include appropriation. So you may be mandated by legislation, but if there's no appropriation to support you, how are you going to do your work? I already talked about Florida legislation enabling you to ask the right questions to collect that data. And then a stakeholder consensus and the ability to remain objective. Once things become legislated, if there's any political pressure from outside, you know, it opens up the door to bias. So we have been talking to states since 2003. The very first state we talked to was North Dakota. Aaron traveled out in February of 2003 to talk to Mary Wakefield Shop. And as we've been talking to states, we've identified just 4 general challenges that they're facing. These include motivational challenges. You're trying to convince policymakers and funders that this is an important endeavor to invest in. Organizational challenges. How are you going to set up a data system? Where are you going to put it? What data are you going to collect? There are analytical challenges. Once you have the data, assuming that you can ask the right questions, how do you then count people? How do you define people by specialty? How do you locate people to places? And then the 4th barrier we've seen is financial. And this affects anyone, even if they have a data system going. Who pays for the system initially, and then how do you sustain it? So first, I'm going to go into each of these challenges and talk a little more. So first I'll talk about motivational challenges. So data-driven workforce analyses are necessary to do a bunch of different things. You can monitor longitudinal trends in supply and distribution, and you can establish benchmarks. How do you measure up to the national average? How do you measure up to your neighboring state? Within your state, how do you compare, compared to 5 years ago? Are you making progress or not? Data can be used to challenge anecdotal evidence, and I'll talk more about that. Data can be used to justify funding requests. This is something we've done in North Carolina a bunch. Data can be used to evaluate the success of existing programs, and they can identify uncomfortable truths. So monitoring trends. Our primary care physician growth has been stronger than overall physician growth. This is good news, but it's counter to what the national story has been. And this is one reason why it's good to track state trends. Your situation may look different than us. It may look different from the U.S. We use data to challenge anecdotal evidence. Aaron Freyer calls us data agitators. So what we do is, this graph shows the annual number of births per OBGYN providing obstetric deliveries in our state from 2001 to 2009. Folks have been saying that OB-GYNs and other docs who deliver babies are fleeing the state because of malpractice rates. But when we look at the data, they show that the number of births per OB has actually gone down instead of up, which wouldn't be happening if we didn't have the supply of OBs to meet demand. We use data to justify funding requests. So several years ago, East Carolina University out in the eastern part of the state wanted to develop a new dental school. And at the time, we only had one dental school housed here at UNC Chapel Hill. We prepared a fact sheet with just the FactStrack type of data. What was the distribution, the supply, age breakdown, race breakdown, practice setting, all these different types of variables. We made a report to the UNC Board of Governors who approved requests for new programs in schools. And that report also went to our General Assembly. They used our data to say, yes, it looks like we do have an imbalance in distribution, and this imbalance occurs mostly in the eastern part of the state. Yes, let's build a dental school in Greenville, North Carolina. So they did, and they're up and running, and they have a really intriguing community service learning model. There was another request to start a new pharmacy school in the state. We did a similar report to the dentist and found that actually we had a pretty adequate supply of pharmacists in the state. And the general administration looked at that and said, okay, well, we're not going to approve the brand new school, which was going to have an estimated $80 million in capital costs. But they did approve an expansion of the current UNC School of Pharmacy out to the western part of the state as a satellite campus, which did not cost nearly as much money. And in fact, the revenue came from Asheville and the UNC School of Pharmacy. And then we also used data to look at medical school and GME expansion. Our data has been used to identify geographic and specialty areas that have been in short supply in the state, and we're still trying to figure out policy ways to do something about this. We use data for evaluation. In North Carolina, we have what we call this medical student tracking project, and we do this each year. In 1993, the North Carolina legislature expressed concern that there was a primary care shortage. So they required the 4 medical schools here in the state to develop programs to increase the number of primary care graduates that they put out.
Sure.
They set a goal for UNC and ECU at 60%. So they wanted 60% of UNC and ECU grads to go into primary care. They set a goal for Duke and Wake Forest, which are 2 private medical schools here, at 50%.
Okay.
And then they require the UNC Board of Governors to track the progress and report regularly or annually to the General Assembly. So that's what we do. We track this each year, and here's a snapshot of what we found. So we put out the same data each year. We split the data out by the 4 medical schools, and we now have the Campbell School of Osteopathic Medicine, so we will be adding them down the road as well. So the class of 2007, what are they doing in 2012? So what this chart shows is the percent of graduates by school who are practicing in primary care anywhere in the U.S., and then those who are practicing in primary care in North Carolina. East Carolina University, or ECU's, mission is very focused on primary care. They only admit students from North Carolina, and so they have done a really good job putting primary care docs out who tend to stay in the state. UNC follows. It's also a state school, and so their primary care mission is a little higher. Duke does not have a high percentage of folks going into primary care, and that's not surprising. They turn out a lot of specialty docs. And the primary care docs they do turn out, I think, tend to be internal medicine. And one thing I should note about primary care is that in our primary care definitions, we include OBGYN. The federal designation does not include OBGYN. Here's another way to visualize our medical student tracking data. And this graphic really resonates with people. So the top part of the pyramid, we have the total number of graduates that are in training or practice as of, it should be 2012, not 11. We had 411 grads. 208 of those had an initial residency choice of primary care. Of those, 132 were actually in training or practice in primary care in 2012. Again, another typo. Of those, 56 were practicing in primary care in North Carolina, and only 8 were practicing in primary care in rural counties of North Carolina. Now, if I'm a state legislator, I'm wondering what my return on investment is. If we're funneling state money into all 4 medical schools, more into UNC and ECU than Duke and Lake, I'm going to have some questions and some concerns. So our admissions committees are very interested in these types of data. All right, moving on to organizational challenges. this is where, once you can motivate people to invest in the data system, how do you get them to work together? So in some states, we have heard that the licensure boards don't see data collection as their role. They are there to help regulate the current workforce. Or maybe they want to help, but they lack the staff, so they can't engage in data collection without additional funds. Or maybe they have the staff, but they don't have the resources to add different questions and change things as they go along. Organization of the licensure body, and I already mentioned this before, but how the licensure board is organized affects their flexibility in being able to collect data and help with the data system. So is the licensure board housed within the government, or is it an independent entity? And then, do you legislate this? And we've already talked about that as well. And there are more organizational challenges. So as you engage in trying to set up a data system, lay the groundwork, it can really raise some issues around turf. You know, some people want a data system in their shop. Others want the data system in their shop. Others think it's a great idea. Some don't think it's a good idea. And there can be a lot of fighting. And this can get in the way of setting up your data system. And then you have to think about where you want to house the data. Do you house the data system in a professional association? Do you house it within state government? Do you house it within an academic institution like we are at SHEP? How do you protect confidentiality? And this is a big deal. People who work with data on a regular basis have good ways to handle data security. And then part of that also is who can access the data and for what purpose. So once you start collecting data, are you able to share it with others who can do more research on their own? And the last one here is, how do you protect data objectivity? In order to be trusted, your data have to be reliable and they have to be objective. Once you start getting into recommendations or using your data to make advocacy-based points, your trust in the data really goes down. We have some analytical challenges. Assuming that you can ask the questions you want and assuming you get good response rates, then how do you work with the data? So one of the challenges is, how do you define a healthcare worker? How do you define if they're actively practicing versus not practicing? Do you use headcount or do you use full-time equivalents or FTEs to describe your workforce? How do you locate people? In North Carolina, we get up to, say, 3 addresses. One can be their practice address, one can be their business address, which may not be at the same location as their practice, and one may be their home address. In some states, all you have is a public address. You don't know if you're getting their home address or their practice address. It's wherever they want their licensure materials to be sent. And then how do you describe people? So one of the challenges that we're grappling with right now is, how do you define specialty? How do you define primary care? So for example, in North Carolina, who's in primary care and how much primary care do they report providing? This chart shows our primary care professions, and we define primary care as general practice, family practice, pediatrics, internal medicine, and OBGYN. This shows the percentage of their total self-reported clinical hours that they say are spent in primary care from 1999 to 2008. We see that OB-GYN is between 40, 45, 46%. Internal medicine reports spending about 72% of their time in primary care. That means the other 28% is spent on specialty care or other. And family practice is spending 90% of their time in primary care. So what are they doing the other 10%? But we did a similar analysis for specialists, they are also reporting that they do primary care. So the black line at the bottom of this chart shows our physician specialists. So anyone who's not family practice, general practice, peds, internal medicine, or OB-GYN. And they're reporting a little over 20% of their time is being spent on primary care. And let's not forget allied health. So the problem with allied health, great professions, the problem with allied health is that not all of the professions are licensed. So in North Carolina, that means we can't track everyone. We have occupational therapists and physical therapists, but we don't have medical assistants. So if we want to do allied health studies, we have to rely on other data sources and other methods when we do the analyses. I've listed out some of the projects that we've done in the past. The first one is our Allied Health Job Vacancy Tracking Project, which tracks demand for specific allied health workers in the state. And we had a graduate student count job ads for 10 weeks looking at the Sunday paper. And they would count the number of job ads in each of our 9 AHWTAC regions. And then we would put together some indicators of demand. And what we found, word on the street, was that this was a pretty good barometer of what was actually happening in the market. We did a hospital workforce trend analysis using data from our North Carolina Hospital Association. They do workforce surveys of all their member hospitals. So we were able to tap into that data source and look at vacancy rates and turnover rates and the time it took to fill positions. We did a State of Allied Health brief, as we called it, and we used Bureau of Labor Statistics and our Employment Security Commission data for those. And then before we were really doing more of the shorter briefs and the survey types of projects, we would do a more in-depth focus on an allied health profession. So the one I've listed here is clinical lab sciences. And for that, we used a bunch of different sources, including professional association data. So we use those in the absence of licensure data. The last set of barriers is financial. And so where do we get the money to support data collection? There are startup costs to setting up the data system. So if you're a state that doesn't have a data system in place and you're interested in starting one, do you build something completely new? Do you, get a new building? Do you build something from scratch? Or do you embed a system within an existing entity who already has the infrastructure to do this type of thing? You have to think about the cost of maintaining the system so you can assure longitudinal data. It's great to have just a snapshot of data. It's even better to be able to go back and look at how you're progressing. Who should bear the cost of this activity? Should the licensure boards bear the cost? Some states have thought about raising the licensure fees to subsidize its work. Should the taxpayer pay? Should AHWTAC pay? Good question. Should private foundations pay? How about professional associations? And then staffing costs. For something like this, you need someone who is good with data management. You need someone who can analyze the data. Cartographic skills are great. I'm a geographer by education. I make maps, and it's fun, and they resonate with people. You need someone who can do some policy analysis. So depending on what you're using the data for, you want someone who's kind of savvy with policy. And then you need someone who can write, someone who can present, someone who can visualize data. So how do you pay for all this? That's a big question. That's really hard for states to figure out. So I'm getting close to the end, but I'd like to make a few suggestions. So as you're thinking about data collection, as you're laying the groundwork, you need to have a clear idea of who will be collecting the data, who will be cleaning the data and analyzing the data, who's going to be writing the reports, and how are you going to disseminate the data. You should also have a clear idea about what the policy questions are in the short term, medium term, and the longer term. These kinds of questions can help guide your efforts, and they can help convince people that this is important. we've been working with the Robert Wood Johnson Foundation. Erin Flair has been one of their nurse research managers, and we put out a series of 3 briefs on state-level data collection. So it's a really long link, but I've pasted it in here. You can go back to it later when we post the slides. But we have just little 2-page briefs that talk about why the states might want to collect data, some of the organizational barriers, and some of the analytic challenges. So that's another good resource. For dissemination, I've already talked about staying objective. People have to trust your data. And so one of the things I do is say, repeat after me, the data are the data. We tell our legislators that the data are the data. You got to remember that. Know your audience. Who are the key stakeholders? Write to them. Get the data from their perspective. But remember, keep it objective. And when you write your reports, when you disseminate your information, write short, easy-to-read briefs and use lots of graphics to illustrate. Some folks like maps, some like tables. Some people are not data people, so you have to make it easy for them. One of the things we try to do in North Carolina is run our findings by key stakeholders before we release them. Do the data test, the sniff test, and sometimes we'll put out some things to our reviewers and they'll say, that's crazy pants, that's not what's going on here at all. And we talk about ways that we could recut the data or investigate a little further. And then another thing we like to do is give stakeholders a heads up if the findings are going to affect them. When we did our dental fact sheet several years ago, we ran our results by the dental board as a heads up because once we put this report out, we knew that they were going to get inundated with comments and calls and complaints and all sorts of stuff. Why are you using our data to say that we need more dentists? And it was really good. So we gave them a heads up. They said, oh, thank you so much. Now we'll know what to expect. I like this last slide because it shows the types of people, the types of organizations that use workforce data and tells them what they use the data for. So, for instance, there are government organizations, federal, state, local, who use data to make policy decisions. They allocate funding. They use them to plan programs, use them for evaluation. They use them to apply for HPDS status, and they use them in grant proposals. Then you have the workforce policy folks who do many of the same things. You have your educators and researchers who are trying to plan for new schools and programs. They're looking at pipeline and diversity issues. Funders use these. So funders use our data to say, oh, well, yeah, maybe we really do need a program to address this. So our data help them to allocate funding. You have your national organizations and your professional associations that use data. Some of them use data for advocacy, but our mantra is the data are the data. We provide it, and then other people use it to suit their purposes. But as long as they cite the data and they know the data came from chefs and, oh, yeah, those are good, then we're okay. And then you have other people. We have students ask for our data. We have media, lawyers ask for our data. Our data are used to advertise for continuing education seminars. So there are lots of different people who are affected by the data, who use the data. Which of those people might be able to pay? That's a good question. So I think this one is really my very last slide. From a selfish standpoint, I am very interested in knowing what you all are doing in your respective states. I have presented some of the barriers that I have observed over the years, but are there different ones that I haven't included here that you're facing right now? I would love to hear from you. And then the second one, are you looking for more information? Is there any way we can help? Let us know, because that's what we're here for. That's what we're funded to do. We're happy to help. We're happy to chat. So my contact information is listed here. If you go to the Health Workforce TA Center at healthworkforceta.org, there is a contact link up at the top right. If you go there, you can also contact us that way. And you can also call the New York line, and they'll be able to speak to you as well. So with that, I am done, and I'm happy to start fielding questions.
Thanks, Katie. That was great. At this time, we'll start the Q&A session. Once more, you may ask questions using the chat panel on your screen. I'll go ahead and start you off with one. Katie, what are the benefits of using licensure data instead of survey data?
Very good question. So one of the biggest benefits is that you are able to get 100% of your workforce. If you're involved in collecting data through the licensure process, and you know that you have to be licensed to practice, in order to practice, you're capturing 100% of the workforce. The other thing is that for us, we find that it's much cheaper in the long run to do it through the licensure system than it is to send out surveys, because then you have mailing costs and you have follow-up costs. You don't get very good response rates all the time with surveys. Granted, it depends on how you deploy those surveys. So New York, I know that you have attached the survey to your licensure forms, and I think that attracts more respondents than just sending out a cold survey. So from our standpoint, it's much easier to get the licensure data. It's a better response rate, and it's cheaper.
All right, thanks. Next question. Do you collect demand data?
We have not typically collected demand data. We have tried, as I mentioned, to look at demand data on allied health workers, and that's when we looked at job ads. Collecting demand data is a lot harder because we can't get that from the licensure boards. And as we do not have funding to collect the demand data, we have not been able to do that.
Okay, that's fair. How have you navigated standardizing data across professions without compromising the nuances of the different professions?
Oh, another excellent question. So in North Carolina, we have our own minimum data set. So we added respiratory therapy, I think, back in 2004, and we added occupational therapy in 2006. And before we added them to our data system, we gave them a list of questions, a list of topics that we wanted them to agree to answer, and they agreed. And these questions were around demographic characteristics, so your basic race, age, sex, your training characteristics, where did you go to school, when did you graduate, what was your degree, say ADN versus DSM, that type of thing. What are your practice characteristics? So what is your employment setting? If they're specialty based, what is your specialty or what is your area of practice? And we made that pretty consistent from board to board early on, and we've been able to continue that. So for all of our professions, we have the same general categories, but we also have the flexibility to say, okay, physicians, what's your specialty? And we have, I don't know, 100 specialties that they can choose from. But for occupational therapy, we might have 6 or 10. So we've been able to balance that really nicely, and we have good comparable data across all of our professions. Now, granted, we were able to start this in the 1970s, and we built it from the ground up. Starting that now is a little more challenging, because resources are a little more constrained. It's harder to share data. It takes money now to adjust electronic licensure forms or electronic surveys. So I do recognize that there's some challenges there.
Okay, next question. How might we all best share item language around some of the tricky topics you have mentioned, active, inactive, practice setting, for some examples?
I'm sorry, David, can you repeat that?
Yes. How might we all best share item language, I guess question language, around some of the tricky topics you mentioned, active, inactive, practice setting?
Well, WWAMI, University of Washington, their Center for Health Workforce Studies, has a repository of questionnaires that they have collected from different states. So that might be one place to start to look and see what some of the other states are asking and how they're asking it. Excuse me. HRSA has also been involved in trying to come up with some common language around questions. That might also be another place to start. The Forum of State Nursing Workforce Centers, or State Centers for Nursing, and the National Council of State Boards of Nursing has done something very similar for nursing. Our TA Center might be a good place or a good forum to do this as well. So there are lots of different options. And we can post some of those resources to the TA website and then just get a dialogue going.
Okay, Katie, thank you. What is your experience advancing data through new media?
So the way I interpret new media would be social media, perhaps, maybe new visualization tools on websites. We have not entered into the world of social media yet. We're not ready to go there, and we'll be dragged kicking and screaming into the new century of social media. When used correctly, I think it can be an effective medium for advancing data, for sharing data. We just haven't gone there yet. We do, however, want to do much more visualization on our website. We want to put in some interactive maps. We want to put in some query systems. We want to just do different graphical displays of our data to make them more meaningful and more catchy. So that's one thing we are going to try to do. And I know some states are doing this now. They're putting up some interactive systems on their website, and they're really getting pretty slick. So I'm jealous of those states if you're one of them.
Okay. Do you develop your own forecasting models? Or is this something you leave to others to do?
We do some of that ourselves. So we currently have a project to develop an open source physician projection model, and that's a very complex, in-depth model that we'll be releasing, I think, by the end of June. That will have some interesting visualization and interactive opportunities, and that's right now just for physicians. You'll be able to look at different scenarios. So one of the scenarios might be, well, what if we increase GME slots by 5%? Does that have any effect on physician supply and distribution? So that's one thing that's a special funded project that we wouldn't do if we didn't have funding. There are some basic forecast models that you can do in Excel, something you can do on your own. But there are other experts out there, and I think they're on the call too, who are doing models and who do a very good job with their models. So that type of thing, it depends on your comfort level. That might be a really easy thing to partner with someone like IHS and Tim Dahl, because this is the kind of thing he does.
Okay, Katie, here's a long one. At the 2013 FSMB annual meeting, an attendee raised the issue of whether or not it was ethical to require all those seeking licensure or renewal of licensure to complete a survey on the grounds that this was disingenuous. In short, completing a survey was not truly a requirement. Completing a survey should be totally voluntarily. What do you think?
I think that's a very interesting question. So I know that the FSMB has been trying to get all of their member boards to collect a comparable data set across states for physicians. I know that North Carolina, our medical board has been collecting those questions for years, and we sat down with them to look at the difference between our questions and the FSMB questions, and they were able to adjust questions to make us happy and to make the FSMB happy. I know that in North Carolina, only certain questions on the licensure form are required, but there's no good indicator of the ones that are not required, so we get a really good response rate. I would love to be able to make a survey required because you'll get everyone answering, but I think that's not realistic. That's why, for me, I prefer to go the licensure route, beyond just because it's what we do, but because you get that really good response rate, and you don't feel like you're forcing people to take a survey, to take extra time out of their day to do it.
Okay, Katie, here's another one. How do you measure population need against workforce distribution?
That's another really good one. This, I think, is where you have a really good opportunity to tie in other secondary data sets. So I know that some states, and I'm so jealous of this, some states have access to their Medicaid data. Some states have access to Medicare. They're all payer data systems or data sets and other claims data. If you know what the population is using, you have the utilization data, you can benchmark that against your supply and try to assess the adequacy of your supply compared to what the population needs. This is another thing that we're doing with the physician model that I talked about, where we're comparing where utilization and supply meet, and so we can determine if there's a shortage or a surplus. We're going to try not to use those words in the model, but that's what we're getting at. So it's a really hard question, but it provides a really good opportunity to pull in some other data sets and make something really cool.
Okay, Katie, thank you. I think we have time for one more question. For those of you whose questions we have not been able to get to, just a reminder, we're going to do our best to answer them and post them to our website later on, along with the archived webinar. There will also be the slides posted there as well. Katie, last question. We are just starting to launch a health workforce data collection effort in our state. How can we learn more about what other states are doing?
Oh, another good question. We've been full of good questions today. Thank you all. So if I'm a state that's wanting to set up a data system and I want to figure out what's going on in other states, what would I do? Through this Health Workforce TA Center, we are trying to develop a resource to show what states are collecting data, who in those states is collecting data. So is it the PCO? Is it the SHUT Center? Is it the state government? We're going to try to compile that information. We're thinking about trying to do an interactive map so you can click on a state and see what's going on, and we can connect you to people in other states that way. So we'll be collecting this information in the coming months. If you are collecting data in your state, or if you know of someone that is, please get in touch with us. We know a lot about what's happening in some of the other states, but I don't think we know all. So any help you could give us would be greatly appreciated.
Thank you, Katie, and thank everyone for attending our inaugural webinar. Once more, this is the first in a 6-part series, and we hope to see you again here in the future. Thank you, and have a good day.